Welcome back to this next video in which we are studying headaches. Okay, so we're currently in the process of discussing intracranial hypertension, which is raised intracranial pressure, and we've discussed that the raised intracranial pressure is going to lead to the activation of meningeal nociceptors all over the brain, and therefore we're going to get a bilateral headache that's in all the regions where meningeal pain can refer to. So, for instance, in the frontal regions, the periorbital regions, the temporal regions, and the occipital regions. So it's going to be all over the head. We've also discussed the fact that this headache is going to be pulsating in nature because it's the activation of the meningeal nociceptors, and most of those meningeal nociceptors will be in the walls of meningeal arteries and extraaxial brain arteries. We discussed that you'll have this headache every day for as long as the intracranial hypertension remains there. Until the intracranial hypertension is gone, you will still suffer from this headache. And we've discussed the fact that it's going to be worse in the morning, and the reason it's going to be worse in the morning is because, as part of normal physiology, intracranial pressure fluctuates on a circadian basis. And intracranial pressure in perfectly healthy individuals will be highest in the morning and then lowest in the evening. And the reason for that is that during the night, the resorption of CSF in the arachnoid granulations goes down, and therefore CSF builds up to raise the intracranial pressure. So by the morning, the intracranial pressure is at its highest, and then throughout the day, resorption of CSF goes up, and therefore the amount of CSF goes down. So by the evening, the intracranial pressure has reached its bottom level. So that is why the headache that you get with intracranial hypertension is worse in the morning. We've also discussed the fact that the headache that you get with intracranial hypertension is going to be worse when sneezing and coughing, because sneezing and coughing are going to raise the pressure within the trunk of the body, and they're then going to force more blood up to the head, and therefore you're going to end up with more blood intracranially. And then we apply the Monroe Doctrine over here and say that if you increase the amount of blood in the skull, of course that's going to raise intracranial pressure, and therefore that's going to make the pain of intracranial hypertension headache worse. Right, so we've now described the type of headache that you get with intracranial hypertension. I now want to discuss some of the associated symptoms that you get with intracranial hypertension. In particular, I want to stress what the really, really dangerous thing about intracranial hypertension is, which is that it can cause you to go blind. That's why this is an extremely dangerous type of headache. Then we'll go on to discuss things that can actually lead to raised intracranial pressure, and that's going to be very simple. We're simply going to apply the Monroe-Kelly doctrine and say, well, if the amount of brain goes up, then that's going to lead to intracranial pressure going up. If the amount of CSF goes up, that will lead to intracranial hypertension, or if the amount of blood in the skull goes up, that could lead to intracranial hypertension as well, and we'll work through them one by one. Okay, right. So, accompanying symptoms. I think we'll go down to do accompanying symptoms rather than sideways. So, let me get a nice colour then. So, some of these you should be able to guess. Of course, as always, we're going to have nausea and vomiting as accompanying symptoms. And again, this will be the same mechanism as we previously discussed. When the cerebral hemispheres are experiencing pain, there are pathways connecting the cerebral hemispheres down to the vomiting centre in the brainstem reticular formation, and they can activate that vomiting centre just as the chemoreceptor trigger zones would be capable of activating that vomiting centre. And depending on how much you activate the vomiting centre, you'll either just get nauseous if it's only a little bit activated, but if it gets really heavily activated, you will actually end up vomiting. So accompanying the pain of the headache, you will get nausea and vomiting as always. Okay. Next accompanying symptoms, you can get meningeal symptoms, and again we can understand why you can get meningeal symptoms, because the pain is going to originate from the activation of meningeal nociceptors. Now, to get meningeal symptoms you need to have a lot of activation of meningeal nociceptors. It's not enough just to activate meningeal nociceptors a little bit. To get the meningeal symptoms, and I'll remind you that the meningeal symptoms are photophobia, phonophobia, knuckle rigidity, and the fact that the headache is worse with physical activity. To get these properly, you need to have massive activation of the meningeal nociceptors. If the intracranial hypertension is absolutely horrific, if it's very, very high, if you've got ridiculously high intracranial pressure, then of course it will activate the meningeal nociceptors a huge amount, and then it will lead to the meningeal symptoms. However, the less the intracranial hypertension is, the less likely you are to have meningeal nociceptor activation high enough that you will actually get the meningeal symptoms. So what I'll put here is a few meningeal symptoms usually, because the meningeal symptoms aren't usually that pronounced in intracranial hypertension because the activation of the meningeal nociceptors isn't quite great enough to get the full strong meningeal symptoms. But if you do have very high intracranial pressure, then you might get high enough activation of the meningeal nociceptors to get, the proper meningeal symptoms. So the meningeal symptoms can occur in intracranial hypertension, but they're usually only there to a tiny little extent because the activation of the meningeal nociceptors isn't quite big enough to cause the meningeal symptoms. Okay, so meningeal symptoms, and then we don't need to talk about autonomic symptoms because that was something that cluster headache alone has accompanying it. The next thing I want to discuss is the effect on the eyes of intracranial hypertension. The fact that it can damage vision. It can cause your vision to become blurry and then you can even lose vision. So I want to explain this. So, why does having raised intracranial pressure affect the eyes so much? Well, it affects the optic nerve hugely, and the reason it's going to affect the optic nerve is that the optic nerve is still covered by a meningeal layer even after it's left the cranial cavity and is in the orbital cavity. So remember, the optic nerve, and I'll just see if I've got a picture that I can use. Oh no, I've got rid of all the pictures I can use. So remember, the optic nerve goes through the optic canal, and when it goes through the optic canal, it doesn't leave behind the meninges. It takes a coating of meninges with it. So let me just draw a picture of this. So we will draw the right optic nerve for an example here. So in yellow here, this is the actual nerve, like so. So I'll just colour it in, and it will be going into the eyeball. So I'll just draw a bit of the eyeball here. So the eyeball is going to be here, and I'll just draw it really crudely as a purple circle here. Okay, so this is the right eyeball here, which the right optic nerve is going into. Now, the optic nerve, even after it's in the the orbital cavity, it's still covered by the meninges, and this is the really important point to understand. So it's going to still be covered by pia mater. So what colour should I do pia mater in? I think we'll go back to aquamarine. So covering the optic nerve here is a layer of pia mater, like so. So we've got the pia mater there, and then of course on top of the pia mater you're then going to have the subarachnoid space, and then around the subarachnoid space you'll have the outer meninges. So in mint green here is the arachnoid mater, like so, and then we'll have the dura mater as well, and I'll just show the dura mater with one layer rather than distinguishing the two separate layers of the dura mater, but of course this will be made up of both the meningeal and the periosteal dura mater. So that's the dura mater there in purple. So here's our optic nerve covered by pia mater with subarachnoid space in here, and then arachnoid mater and dura mater around it. So this is called the meningeal sheath of the optic nerve, and it's a bit out of proportion. It's not quite the size of the eyeball, the same thickness as the eyeball as my picture implies here, but this gets the basic concept across here. Right. So the fact that the optic nerve is covered by a layer of cerebrospinal fluid in this subarachnoid space here is why the optic nerves can be so detrimentally affected by raised intracranial pressure. You see, if intracranial pressure is raised, that's going to lead to the pressure in all of the subarachnoid space cerebrospinal fluid everywhere being raised. So the pressure in this cerebrospinal fluid here surrounding the optic nerve is now going to be raised, and that's going to be pushing in on the optic nerve. So you might think, oh, well, this is why it's going to damage it. It's going to compress the optic nerve. Well, it's a little bit more complicated, the story, than this. So, we need to remind ourselves about the central retinal artery and also the central retinal vein. So remember when we were discussing the blood supply to the eyeball, when we were discussing the ophthalmic artery, we saw that one of the first branches that the ophthalmic artery gives off is the central retinal artery. So I'll put this on here. So I'll get a thicker pen. So the central retinal artery, remember, it penetrates through the meningeal sheath. So it's here. Remember, the ophthalmic artery goes through the optic canal with the optic nerve, but it doesn't stay inside the meningeal sheath. It's outside of the meningeal sheath. So in red here, this is representing the ophthalmic artery here, but then the first branch it gives off pretty much is this central retinal artery that penetrates through the meningeal sheath of the optic nerve into the middle of the optic nerve and then runs in the middle of the optic nerve. So that is the central retinal artery, which for short I'll call the CRA. Now, the central retinal artery, it will supply blood to the optic nerve tissue, and it will also supply blood to the retina of the eye, which lines the inside of the eye, and is of course where the cells that will process light are present. So this is the central retinal artery. Now, it's not important for us to know about the central retinal artery as far as the pathophysiology in intracranial hypertension is concerned. We need to discuss something else called the central retinal vein. I just wanted to remind you of the central retinal artery. So there's also a vein that is going to drain the blood from the retina and from the optic nerve, and this also runs down the middle of the optic nerve. So here in blue, this is the central retinal vein, and then again it will penetrate out of the meningeal sheath of the optic nerve, and then it's going to drain into a vein called the superior ophthalmic vein, which I'll have there. Okay, so thinner pen and let's write some of this down. So there is a central retinal vein, which I hope you're happy with me abbreviating down to the CRV, and I'm showing that in this position here. This vein that the central retinal vein drains into, this is the superior ophthalmic vein. So there are two major veins draining blood from the orbital cavity, the superior ophthalmic vein and the inferior ophthalmic vein. The superior ophthalmic vein is above the eye and the inferior ophthalmic vein is below the eye. Both of these ophthalmic veins, they will pass out of the superior orbital fissure, and for this it will actually be helpful for me to once again draw a picture that you're probably utterly fed up of me drawing, which is the picture of the inside of the cranial cavity. So again, here is this picture of the inside of the cranial cavity drawn from above. So here is the anterior cranial fossa, the two clinoid processes there. The sella turcica is here. At the front of the sella turcica, you've got the optic chiasmatic groove there. Here's the petrous portions of the temporal bone and the foramen magnum. Okay, right. So remember, the superior orbital fissure is in this position, so both the superior and the inferior ophthalmic veins will come through the superior orbital fissure. They'll then have to penetrate through the layers of the meninges, the outer layers of the meninges, so they'll go through the periosteal and meningeal duromata, they'll go through the arachnoid mater, they'll then end up in the subarachnoid space here, and then what they are going to drain into is the cavernous sinus, so they'll need to go through the subarachnoid space to where the cavernous sinus is here, and then they'll have to penetrate through the walls of the cavernous sinus. And remember, the top of the walls of the cavernous sinus will be made up of arachnoid mater and then meningeal duromata, so they'll penetrate through that to drain their blood into the cavernous sinus. So just to complete up this little flow diagram here, the superior ophthalmic vein is going to drain into the cavernous sinus along with the inferior ophthalmic vein. Okay, so that's just a little bit of background anatomy. The important bit for us to understand is that the retina and the optic nerve is drained by the central retinal vein, which then comes out and drains into the superior ophthalmic vein, which will then go out of the superior orbital fissure into the cavernous sinus. Now, why am I so interested in the central retinal vein? Well, when the cerebrospinal fluid pressure goes up, this is indeed going to compress the optic nerve a little bit. It's going to put pressure on the optic nerve. Now, that pressure is not going to be big enough to block the central retinal artery. Arterial pressure is very high, remember, so it's not going to do anything to the artery. The artery will remain open. But the venous pressure in the central retinal vein is very low. So this is going to be compressed, and it's going to be compressed to the point that it's shut. So when pressure goes up here, it's going to compress the central retinal vein, and now that's going to block blood being drained from the optic nerve and also from the retina. So, what will happen then if you block this vein here, especially the bit that might be blocked is the portion that actually passes through the subarachnoid space here, because that's actually exposed to the high pressure in there. What will happen is, of course, the blood will back up, so the pressure will go up now in this vein. Now you might say, well, maybe that will now outweigh the pressure here, and therefore it will open back up again. But what's more likely to happen now is that means that blood will back up in the capillaries that would drain into the venules, and then the venules would drain into the veins, and then the fluid has to go somewhere, so it will end up going into the tissue fluid. If you build up the pressure in capillaries too high, it'll end up pushing fluid out of the capillaries into the tissue fluid. So, obstructing the central retinal vein then is going to lead to fluid accumulating in the optic nerve. It's specifically in the optic nerve. Remember, that's because the optic nerve is closer, basically. You might be wondering, well, why isn't the fluid going to accumulate in the retina? If you think about it, if we're obstructing the central retinal vein somewhere over here, the blood is going to back up. Where's it going to go out first? It's going to end up going out in the optic nerve rather than the retina, because the retina is further away. So the vein pressure will go up, that will cause the venular pressure to go up, which will then cause the capillary pressure to go up, and when the capillary pressure goes up, fluid will leave the capillaries into the tissue fluid. So what's actually going to happen here is the optic nerve is actually going to swell. Now you might find that a little bit counterintuitive, because we've got such high pressure here in the subarachnoid space pressing in on the optic nerve, and now the optic nerve's actually going to end up swelling, not getting smaller, getting bigger. It's going to swell because the fluid is accumulating because you've obstructed the venous drainage. Specifically, a lot of this fluid ends up accumulating in this right front bit of the optic nerve here, because of course that's not surrounded anymore by the cerebrospinal fluid, so it's not victim to the pressure. So you end up getting a lot of swelling, a lot of edema in this portion of the optic nerve, the portion that is at the junction with the eyeball, and that's the portion where the fibres are actually going to go to the retina. And of course they're the axons of the ganglion cells of the retina, so they'll be going in all directions from the retina, and that's got a special name. That's called the optic disc, because you can see this when you look at the back of the retina with an ophthalmoscope. So the junction between the optic nerve and the retina is at the back of the retina, and it's called the optic disc. And I think actually optic disc is usually spelt with a C like that rather than a K. It probably doesn't matter, well, I'm sure it doesn't matter, but I'm more used to seeing it, I think, with a C rather than a K. Okay, so you're going to get optic disc swelling as a result of the increased intracranial pressure, is what I hope I've convinced you now. So let me just draw a little picture of what this is actually going to look like when you look at the back of the retina with an ophthalmoscope. So normally, when you look at the back of the retina, and I'll just get an appropriate colour to do this in. So normally, if you look at the back of the retina, and let's do the right-hand eye. So if you use an ophthalmoscope to have a look at the back of someone's retina, you usually see something like this. So this is the retina, and you will see the optic disc normally in this sort of position here, and it looks like a yellow blob, like so. And this is where the optic nerve meets the retina, and of course this will contain all of the axons that will then go all over the place over the surface of the retina. So this is what the optic disc normally looks like. Now, if you've got optic disc swelling because of the raised intracranial pressure and what we've just discussed will happen, you're going to get the optic disc looking very different. So now let me draw what it can end up looking like when you've got optic disc swelling. So again, here is the retina, like so, and now you can end up with a much bigger optic disc, and it's no longer in that beautiful circle shape with clear boundaries. You can see I drew very sharp boundaries previously. Now, once we've got a swollen optic disc, it's going to be bigger, and the boundaries aren't going to be as clear, they're not going to be as well defined. It's more fuzzy, the boundaries. This is what optic disc swelling looks like. Now, of course, this doesn't do any good for the conduction of action potentials along those axons, having all this bad fluid around those axons and the optic disc swelling like this. This doesn't do any good for the conduction of action potentials, and indeed some action potentials now won't conduct along those nerves in the swollen optic disc because of the problems that are going on there. Okay, so what this can lead to then is damages in vision. It can lead to blurred vision. So this is one of the major accompanying symptoms with intracranial hypertension, that you can start to get blurred vision. And this, of course, will be in both eyes. This optic disc swelling will be occurring bilaterally. Now, there is an important piece of terminology here, which is papilledema. So let me just write this down here. So I'll get a little bit more space. So this is a very important word that people often get confused about the meaning. So papilledema. People often think that papilledema means the same thing as optic disc swelling, that you can just use it interchangeably with optic disc swelling, i.e. that this is papilledema. Papilledema is not, strictly speaking, the same thing as optic disc swelling. Papilledema, strictly speaking, is bilateral optic disc swelling. So in both eyes you have to have optic disc swelling, and you have to have raised intracranial pressure. So papilledema is the name given to bilateral optic disc swelling that is specifically caused by raised intracranial pressure. So, in intracranial hypertension, you do indeed get papilledema, but there are loads of other causes of optic disc swelling beyond intracranial hypertension, and those different causes of optic disc swelling might just cause optic disc swelling on one side of the eye, on one side in only one of the eyes. You would not describe that as papilledema. So I'll say it again: papilledema, only use this word for optic disc swelling that is bilateral. You've got it in both eyes, and it has been caused by raised intracranial pressure, intracranial hypertension. That is the only situation that you can use this term papilledema. Okay, right. So having raised intracranial pressure can lead to papilledema, bilateral optic disc swelling caused by intracranial hypertension. This can initially lead to damages in vision, i.e. your vision will become more blurry. However, if it isn't treated, if the intracranial hypertension isn't treated, if it remains there, it can lead to full vision loss. So blurred vision can progress into blindness in both eyes. And that's not correctable. So this is why intracranial hypertension is not to be taken lightly. It is an extremely serious problem and it needs to be treated. I said that secondary headaches were those caused by dangerous pathophysiology. Here we understand why this pathophysiology is dangerous. Okay. So let's summarise what we've just seen. So we've been discussing the accompanying symptoms with the headache of intracranial hypertension. We've said that you will have nausea and vomiting accompanying the headache. You can also have meningeal symptoms if the headaches are very severe because we're activating meningeal nociceptors. And another major symptom of the intracranial hypertension is that you can be getting vision damage. And this is because the intracranial hypertension can block the central retinal veins, stopping the drainage of venous blood from the optic nerves and indeed the retina. This will lead to fluid accumulating in the head of the optic nerve where the optic disc is, and therefore you'll get optic disc swelling that's going to be bilateral, caused by intracranial hypertension, and we call that papilledema. And this leads to problems with the conduction of action potentials through the optic nerve. Therefore you end up with blurry vision, and this can progress to full-on blindness. So it's very important to treat intracranial hypertension before it leads to so much damage of the optic nerves that you're going to be completely blind permanently. Okay, right. So one final thing to discuss about intracranial hypertension before we then go on to discuss the different causes of intracranial hypertension. And the final thing that I want to talk about is the fact that you can also, again, get cutaneous allodynia from the headaches that are caused by intracranial hypertension. So I'll write this down here. So again, with intracranial hypertension headaches, you can get cutaneous allodynia. So we've discussed the fact that when you've got intracranial hypertension, you can be getting headaches every single day for as long as that intracranial hypertension goes on. So you're going to be having very regular activation of those second-order neurons in the trigeminocervical complexes by the primary nociceptive afferents from the meninges. Again, what can now happen is the sensitization of those second-order neurons, and of course, those second-order neurons that are being synapsed onto by the primary nociceptive afferents from the meninges, they will also be being synapsed onto by primary nociceptive afferents from the peripheral tissues. So, for instance, the peripheral tissues in the frontal region, the peripheral tissues in the periorbital regions, the peripheral tissues in the temporal regions, and the occipital regions. They can also be being synapsed onto by those. Because of the convergence that we've discussed at multiple different points along this video. And therefore, when you get the sensitization of those second-order neurons, now activation levels of the primary nociceptive afferents from the peripheral tissues that would not previously have been big enough to cause activation of the second-order neurons now can cause activation of those sensitized second-order neurons, and therefore stimuli that should not be felt as pain can now be felt as pain. So for instance, when you touch the frontal regions, even when you're not actually suffering from one of the headaches, let's say it's the afternoon and the headache's now gone away, you can end up feeling pain from these non-noxious stimulus, and that is because the second-order neurons in the trigeminocervical complex have been sensitized by this frequent activation that they've received. Okay, so cutaneous allodynia is another feature that you can get with intracranial hypertension headaches, and it will be in the regions that are affected by the headache, and it's the same pathophysiology that we've discussed previously. Alright, so now the interesting bit. What are the different things that can actually lead to intracranial pressure being too high? Well, here it's useful to go back to the Monroe-Kelly Doctrine. The Monroe-Kelly Doctrine tells us that intracranial pressure depends on the three things that are inside the skull: brain, cerebrospinal fluid, and blood. So if we are somehow going to get intracranial hypertension, too high intracranial pressure, we must have too much of at least one of these. So I'm now going to go through the different diseases that can lead to too much of each of these, and we'll start off with too much CSF, we'll then go on to too much brain, and then we'll go on to too much blood, and then finally we'll talk about idiopathic intracranial hypertension, which is where we don't think it's any of those and we don't really know what's happening. Okay, so let's start off then with cerebrospinal fluid. So I'll do this here. So, CSF then, too much CSF, and I'll actually put CSF has gone up. What can cause too much CSF? Well, when there is too much CSF in the brain, there is a name for that disease, and it's called hydrocephalus. So, too much CSF, we call this disease hydrocephalus. And hydro, of course, means water, and cephalus means pertaining to the brain, so it's too much fluid in the brain is kind of the meaning of this word. Okay, so hydrocephalus is when we have too much CSF. We can divide hydrocephalus into two different types, which are non-communicating hydrocephalus and communicating hydrocephalus. So non-communicating hydrocephalus, and non-communicating is the really obvious cause of there being too much CSF. And then the other type of hydrocephalus is more subtle, and this is communicating hydrocephalus. Okay, so what are these two types of hydrocephalus? So let's begin with non-communicating hydrocephalus. This is where you have far too much CSF in the brain because there is an obstruction in the path that the CSF is meant to follow. And this is where going over the ventricular system is now helpful. And I've just realised that it hasn't copied perfectly, so let me just fix this picture up, repair the third ventricle here, which hasn't copied over when I've made this next video. Okay, so there's the third ventricle here. So remember, the way that the CSF moves is it's going to be created in the ventricles. So in the lateral ventricle, the third ventricle, and the fourth ventricle, that's where CSF is created by choroid plexus portions of the ependema. Then what happens is the CSF is going to make its way through the ventricular system. So from the lateral ventricles, it goes into the third ventricle through the interventricular foramina of Monroe. Then once it's in the third ventricle, it moves down through the cerebral aqueduct into the fourth ventricle here, and it can go into the central canal that goes down through the medulla and then down into the spinal cord, but that's not a pathway that's going to lead to it getting into the subarachnoid space. And the way that it can then get into the subarachnoid space is from the fourth ventricle through the foramina of Luschka and the foramen of Magendie. So remember, the foramina of Luschka are in between the middle and inferior cerebellar peduncles, like so. They're tubes that go through the brain material, through the pia mater, and then empty into the subarachnoid space. And the foramen of Magendie is the same concept, but now in the midline between the two inferior cerebellar peduncles, and it will drain into the cisterna magna, which is a particularly big pot of CSF in the subarachnoid space. The CSF then in the subarachnoid space makes its way up to the superior sagittal sinus mainly, but other dural venous sinuses as well you can go to, and there are going to be these arachnoid granulations, which are these invaginations of the arachnoid mater into the dural venous sinuses, and the CSF can go into the arachnoid granulations, and then they can be absorbed or resorbed into the dural venous sinus through the arachnoid granulation here. Okay, so that's the pathway that CSF is meant to follow. If we were to stop this communication between the ventricular system and the subarachnoid space, we would no longer have this pathway working, and CSF would no longer be able to get out of the ventricular system. So, for instance, if you were to block, let's say, an interventricular foramen, one of the foramina of Monroe, that would block CSF from coming out of one of the lateral ventricles. The choroid plexus in that lateral ventricle will continue to make CSF, and therefore that lateral ventricle would just swell and swell and swell and swell, and that could raise intracranial pressure. That would be an example of a non-communicating hydrocephalus. So if we blocked one of the interventricular foramina of Monroe, that would cause non-communicating hydrocephalus. If we blocked the cerebral aqueduct, then all of the CSF being produced in the two lateral ventricles and the third ventricle would not be able to drain into the fourth ventricle, and therefore again CSF would build up and up and up, causing intracranial pressure to go up as well, and these ventricles would again swell. If we blocked either the foramen of Magendie or the foramina of Luschka, again that would reduce the amount of CSF leaving the fourth ventricle, and again this could lead to build-up of CSF within the ventricular system, and therefore a non-communicating hydrocephalus. So all of these connections, the interventricular foramina, the cerebral aqueduct, and these foramina here, the foramina of Luschka and the foramen of Magendie, if you block those, that can lead to non-communicating hydrocephalus. So that's what is meant by non-communicating hydrocephalus, and clearly the name pertains to the fact that you're not going to have communication between the ventricular system and the subarachnoid space anymore, so the CSF gets stuck effectively. Okay. In communicating hydrocephalus, the pathophysiology is different. In communicating hydrocephalus, there is not a problem with CSF actually getting from the ventricular system into the subarachnoid space, so none of those tubes or connections are blocked, but instead there is a problem with the CSF being resorbed into the dural venous sinuses. So usually this is caused by a problem with the consistency of the CSF. So if the CSF has the wrong consistency, the wrong makeup, then it might not be possible for it to actually be resorbed through the arachnoid granulations into the dural venous sinuses. So, what sort of things can make the CSF have the wrong sort of consistency? Well, potentially if you've got some blood in the CSF, that changes its consistency, and that might stop it from being able to be resorbed into the dural venous sinuses through the arachnoid granulations. Or if you've got inflammatory exudate in the subarachnoid space in the CSF, that will change the consistency of the CSF, and again that might lead to it no longer being able to be resorbed by the arachnoid granulations. So, communicating hydrocephalus then is obstruction basically of the pathway, whereas non-communicating hydrocephalus is obstruction of the pathway. Communicating hydrocephalus is a problem with resorption. So the problem is resorption, and this is usually because the consistency of the CSF is wrong. So consistency of CSF is a problem. And what sort of things can give rise to the consistency of the CSF being wrong? Well, if you've got blood in the CSF, or indeed if you've got inflammatory exudate in the CSF, this will also lead to the consistency being wrong, and therefore no longer it being resorbed by the arachnoid granulations. And if it's not being resorbed at the same rate and it's still being produced at the same rate, then obviously again CSF will build up and up and up, and intracranial pressure will go up and up and up. Okay, so those are the two different forms of hydrocephalus which can lead to intracranial hypertension. Before we then move on to discussing brain, when the volume of brain material goes up, let me just say something about how hydrocephalus can be treated. So, in both non-communicating hydrocephalus and communicating hydrocephalus, initially you can treat it by reducing the production of CSF, and drugs that can inhibit the production of CSF by the choroid plexus are the carbonic anhydrase inhibitors. So here I'll just put down the treatment, so you can use carbonic anhydrase inhibitors. So remember, carbonic anhydrase is an important enzyme. It catalyzes the conversion of carbon dioxide and water into bicarbonate and a proton. So there are a bunch of drugs that inhibit carbonic anhydrase enzymes, and they are called carbonic anhydrase inhibitors. The most famous example of a carbonic anhydrase inhibitor is the drug acetazolamide. So, acetazolamide can be given, it will inhibit the enzyme carbonic anhydrase, and the enzyme carbonic anhydrase is extremely important in the choroid plexus for producing the cerebrospinal fluid. So if you inhibit that enzyme, you reduce the production of CSF. So I'll just put this in here. Acetazolamide causes CSF production to go down. So CSF production will go down, and therefore the hydrocephalus is going to be reduced. So this is a very effective treatment in communicating hydrocephalus. In non-communicating hydrocephalus, it still doesn't solve the actual major problem, which is that there is an obstruction in the ventricular connections. Therefore, you can use this temporarily to produce some relief of symptoms, because of course it is a good idea to turn cerebrospinal fluid production down whilst you've got this obstruction, but we do still need to actually sort out the obstruction, and therefore to treat the obstruction, what can be put in is what we call a shunt. And this is effectively a tube that is going to connect the blocked ventricles that are expanding because of cerebrospinal fluid not being able to get out of them, and it usually drains that fluid into another body cavity, and it usually goes into the peritoneal cavity. So this has to be obviously fitted by a neurosurgeon. So it usually goes into the peritoneal cavity. So very simple concept then. If, for instance, let's take an example, if the interventricular foramen of Monroe was blocked on the left-hand side here, then of course the left lateral ventricle would be engorging, it would be filling up with cerebrospinal fluid, and we need to somehow drain that. The way that neurosurgeons can treat that is they can put in a tube that will go inside of the brain, will connect up to this ventricle that is full of cerebrospinal fluid and which can't drain, this left lateral ventricle, and then the tube will exit the skull and it will drain into some other body cavity, and the cavity that they usually choose is the peritoneal cavity down in the abdomen, and the CSF will then drain through this tube into the peritoneal cavity, and then it will be resorbed in the peritoneal cavity. So that's what I mean by a shunt. So that's the way we usually treat non-communicating hydrocephalus. But communicating hydrocephalus, we can treat it with acetazolamide, and indeed non-communicating hydrocephalus, we can treat it temporarily with acetazolamide to provide some relief from the intracranial hypertension. Okay, so we'll have a break here, and in the next video we'll discuss more causes of intracranial hypertension. Specifically, we'll move on to the too much brain causes, and then we'll go on to too much blood causes.